Ευχαριστούμε πάρα πολύ τον κύριο Μαμουνά που είναι εδώ και μας τιμά με την παρουσία του. Ευχαριστώ πάρα πολύ τον κύριο Βενιζέλο που με έχει καλέσει στο συνέδριό του για πολλοστή φορά. Και το επόμενο θέμα αναφέρεται σε όλη την ιστορία της χειρουργικής του μαστού. Από την ριζική μαστεκτομή στην αποφυγή ακόμα και της βιοψίας του λεμφαδέα φρουρού. Σας ακούμε. Ευχαριστούμε πάρα πολύ.
Thank you very much. And so we talk now about the evolution of axillary surgery, not overall surgery, because otherwise it would take a lot longer. But again, with the title of From Radical Mastectomy to Omission of Stent Lymph Node Biopsy. And of course, we all know how much progress we have made in the local regional management of early stage breast cancer. This is how we were treated when I was still a medical student. That was many, many years ago. Radical mastectomy, and of course then modified radical breast conservation, and of course the stent lymph node biopsy also revolutionized how we approach the axilla. Now we did that not in vacuum, but we did that in the face of significant escalation of adjuvant systemic therapy. And I think we all have to acknowledge that our success as surgeons and locoregional therapists comes because of all the progress that our medical oncology colleagues have made in chemotherapy, as you can see here, CMF, anthracyclines, taxanes, dose density, anti-HER therapy, carboplatin for triple negative, and immunotherapy, and of course the whole endocrine therapy evolution with tamoxifen aromatase inhibitors, ovarian function suppression, extended endocrine therapy, as well as CDK4/6 inhibitors. So these two trends working together allowed us to de-escalate surgical therapy, not only in the breast, but more importantly in the axilla. And so we know that axillary management has also undergone significant evolution. As you know, from the Halsted radical mastectomy, that was the standard till the late 80s, when the BO4 trial showed no significant survival advantage from elective axillary lymph node dissection, and other trials as well. And even after that trial was presented, still axillary dissection was how we managed the axilla. We did so because it provided us with very good local control. That was the only procedure we can do. Staging was important to understand what the stage of the patient was, and also to help with the decision of optimal systemic therapy. Back in those days, if you had positive nodes, you got chemotherapy. If you had negative nodes, you did not. And of course, then stent lymph node biopsy came to play, and of course, it can provide us with the same prognostic information or treatment decision information with a lot less morbidity, right? So with that in mind, there has been a roadmap, as you already have heard, and what I'm saying, most of what I'm going to say is been said before and will be said again, but essentially we eliminated axillary lymph node dissection for patients that have a negative sentinel lymph node biopsy. We substantially diminished axillary lymph node dissection for patients that have 1 to 3 positive sentinel lymph nodes. And of course, we diminish the use of axillary dissection for patients that present either with clinical or subclinical involvement of the axilla with neoadjuvant chemotherapy and then application of stent lymph node biopsy you heard already in the debate earlier today. So this is NSABP32 for historic purposes. We were discussing in the break, what is the purpose of these large randomized trials? I think the purpose is to give us now the certainty that we did not miss anything back then. By the time we finished and presented this trial with 5,600 patients, everybody was doing stent lymph node biopsy. And for negative sentinel nodes, nobody was doing axillary lymph node dissection. But certainly it's nice to see the curves, that there's no difference in disease-free and overall survival. Axillary recurrence was very, very low. And of course, significant morbidity, less morbidity with stent lymph node biopsy versus axillary dissection. And of course, then that led to the next step, which is what about patients with 1 to 2 or then eventually 1 to 3 positive nodes, ACOSOC Z11, you know that. That trial accrued less patients than originally thought, but nevertheless, with about 900 patients or so, 1 to 2 positive nodes, they had to have lumpectomy and breast radiotherapy, randomized to completion of axillary dissection versus not. No difference. If anything, the sentinel lymph node biopsy line is on top of the axillary dissection. And about 27% of the patients are positive non-sentinel nodes in that trial. So leaving significant number of positive nodes behind did not seem to make a difference. Axillary recurrence was very low, 0.5% with axillary dissection, 1.5% with sentinel lymph node biopsy alone. And of course, in this table, I'm showing you all the studies since, otherwise it will take a long time. But again, what you see here in terms of with the ACOSOC as the sort of the reference, no patients had mastectomy here. 27% had positive node sentinel nodes. You see the axillary recurrence, we talked about it. And then the next study was the IBCSG 2301, some mastectomy patients, 9%. This was with micrometastasis in the sentinel node, more than one micrometastasis, one or more. And again, 13% of the patients have non-sentinel nodes, so less axillary burden. Again, same results, no difference in disease-free overall survival, very low local recurrence. The Amaros trial comparing radiotherapy to completion axillary dissection, 1 to 3 positive nodes. 18% of patients have mastectomy, about a third had residual disease in non-sentinel nodes. Very similar results in favor of radiotherapy. Actually, the local recurrence was less with axillary dissection, however, no significant difference. Less lymphedema, though, with radiation versus completion axillary dissection. The Synodar trial with less follow-up, only 3 years. Again, you see about 44% of the patients positive non-sentinel nodes. More mastectomy patients, progressively we're getting more comfortable in including mastectomy patients, very low rate of local recurrence in 3 years. And lastly, the Senomac trial, the largest so far, 2,500 patients, about a third had mastectomy, 36%, and 44% had positive non-sentinel nodes, very low rate of local recurrence at 5 years. So again, this established pretty much that even with patients 1 to 2, 1 to 3 positive nodes, sentinel lymph node biopsy alone is fine. Whether you want to give radiotherapy to regional nodes or not, thank you, that's a different question, but nevertheless appears to be good local control irrespective. Then going to the effect of neoadjuvant chemotherapy, which you heard before, I won't spend too much time. We know that neoadjuvant chemotherapy downstages the disease in the axilla. With the new regimens that we have nowadays, about 50 to 75% of the patients that have positive nodes will convert to negative. Tremendous opportunity to de-escalate axillary surgery with sentinel lymph node biopsy. And again, what we focus here is to, again, apply sentinel lymph node biopsy and not axillary lymph node dissection, but also there's possibility to de-escalate regional radiotherapy, or very briefly talk about the B51 trial. And again, to mention that this approach is primarily applicable to patients with clinical T1 to T3, clinical N0, N1 disease, because the feasibility and accuracy of sentinel lymph node biopsy for patients with locally advanced breast cancer, clinical T4, clinical N2, IBC, inflammatory breast cancer has not been shown, or in fact has been shown to probably not work very well. Now, whether this is different with the targeted dissection is a different question. So there was a lot of debate initially for patients with clinically negative axilla who would do the sentinel node before neoadjuvant chemotherapy or after. The bottom line is it's better to do it after because there are subclinically involved nodes that you can potentially sterilize. And now meta-analyses have shown no difference in the identification rate or false negative rate whether you do it before surgery or you do it after surgery. But for patients that present with documented disease in the axilla, clinically no positive, is it safe to avoid axillary dissection? Again, here there are 4 prospective trials, as you can see here. The 71, the Sentinel, the Thorsten was involved. The Canadian trial, where they did also immunohistochemistry in the sentinel node, and the French trial. All this showed essentially a false negative rate that was a little bit higher than we anticipated. We wanted about 10%, but it was 14% here. And only the Canadian trial was under 10%, again, because they did immunohistochemistry in the sentinel node and identified disease that was very not apparent otherwise. And of course, consistently in these trials, we saw that if you remove more sentinel lymph nodes, the false negative rate goes down to almost single digit, but it's still high single digit. It's not low single digit. And again, so we said if you're going to apply that, do dual mapping, take at least 3 sentinel nodes. And then, of course, became the issue of the targeted dissection, which is in the 1071, they noticed that when the clip of the biopsy node was in the sentinel lymph node biopsy specimen, the false negative rate was much lower, 6.8%, but was about 19% if the clip was in the axillary dissection specimen. In other words, of course, they didn't take it out with the sentinel node. And of course, that led to this concept of targeted axillary dissection, the data from MD Anderson, when they took patients with positive nodes before, they became clinically non-negative, and then they either counted the sentinel nodes only, the clip node, or both. And what essentially they found was if they just counted the sentinel nodes only, about 10% false negative rate, which is what we expect. If they only counted the clip node, 4.2%, and when they counted both, 1.4%. The reason for that is in about 23% of the times, the clip node did not identify as a sentinel node because there was a bypass of the lymphatics and it went to the to the non-sentinel nodes that became essentially the sentinel nodes. And of course, this was also prospectively validated in the RISAS trial. As you know, in Netherlands, they put a radioactive seed, and when they remove the radioactive seed, they call it the Mari procedure, just essentially the clip node. And with that, they had a false negative rate of about 7%. But in the RISAS trial, where they also added sentinel lymph node biopsy, lymphatic mapping and sentinel lymph node biopsy, with the clip node removal, 3.47%. So again, this is a very accurate procedure, much more accurate, I think, by just doing sentinel lymph node biopsy, even if you remove 2 or 3 sentinel nodes. Of course, the argument against doing TAD and just taking 3 nodes is that the local recurrence rate is so low and is not necessarily any different between the 2 procedures. Here are older studies for patients that have clinical N0, N1, and 2, and they were downstage. They had just sentinel lymph node biopsy, no axillary dissection. And it's with very variable follow-up, but you see very, very low single digits local recurrence. And more recent studies, as you can see here, some with TAD, some with sentinel lymph node biopsy as a single tracer, you can see very low rates. But again, the follow-up here is a little bit shorter. Now, the question that you want to be accurate is not so much in terms of local control, though, because radiotherapy typically will do that if radiotherapy is given. But it's also because of what happens after in terms of systemic therapy. Again, TAD versus sentinel lymph node biopsy in the retrospective study, again, not prospectively, but nevertheless, no difference in the local recurrence. Very, very good. But the reason you want to do it is because it affects what you do afterwards. So you have to be as accurate as possible, because nowadays, as I will show you, there's an issue about whether you need to give radiotherapy or not. So you need to get it right. And of course, adjuvant systemic therapy is very important. And all this has resulted in survival benefits. So you don't want to shortchange the patient and not give him the appropriate treatment because you didn't do the nodal assessment correct. So all these do that. In addition, nowadays in the US and worldwide, we're running several clinical trials that we escalate or de-escalate post-neoadjuvant therapy based on what we find in the axilla and also what you find in the breast, but the axilla also plays a role. So we have to make it right as well. We debated this, so I won't spend too much time on this. What do you do if the sentinel node is still positive after neoadjuvant chemotherapy? And you can see that non-sentinel lymph node positivity is pretty high in some of the studies that I'm showing you here. And therefore, the standard at least is to do an axillary dissection. We're hoping that this study will be negative. We all think they're going to be negative. And when this reports, obviously, that will change the standard. But as you saw from the debate, depending on the number of nodes, the size of metastasis, and number of nodes removed, there is leeway in terms of what people do nowadays. Again, micromets, same thing. They still have a significant rate of non-sentinel lymph node positivity. ITCs, not so much. Again, in this study, it's about 37%. So I think it's fair to say that for ITCs, you probably skip it. For this, we're still going to debate. And as you voted today, some skip it, but some don't. And this is data, again, from ITCs, where they found that about a third of the patients with ITCs in post-neoadjuvant chemotherapy, when they do axillary dissection, you find more disease. But 18% of that was more ITCs, and only 12% were micromets. And of course, whether you had an axillary dissection or not, it didn't make a difference clinically, but again, this is not a randomized comparison. So now shift gear a little bit and let's talk about regional nodal radiation. Can we use neoadjuvant chemotherapy to actually de-escalate regional nodal radiation in the axilla? And again, we know that radiation works well for upfront surgery, but we don't know if it works so well or is needed for patients that have positive nodes but convert to negative. And that led us to the design and conduct of the NSABP-B51RTOG-1304 that we've discussed previously. Even last year, we were here discussing this. And this was presented in San Antonio. Happy to say that the paper has been submitted, and we'll see what happens. But again, this took patients with 1 to 3 N1 disease, positive nodes but documented by biopsy, neoadjuvant chemotherapy, if they became clinically non-negative, axillary dissection, sentinel lymph node biopsy, or both. And then if there were negative nodes, pathologically, randomization to regional nodal radiotherapy or not. The primary endpoint was invasive breast cancer recurrence-free interval. And as you can see, with 5 years of follow-up, we see no significant difference between the two groups. Only 9 events separate the regional nodal radiotherapy versus the no-regional nodal radiotherapy. Most of them were local events in the axilla, in fact. And absolute difference, 0.9%. And again, when you look at all the secondary endpoints, isolated local regional recurrence-free interval, distant, disease-free survival, overall survival, you see no difference so far. Now, the devil sometimes is in the details. We did subset analysis according to stratification factors, no difference in the effect of radiotherapy according to surgery, receptor status, HER2 status, PCR in the breast or adjuvant chemotherapy. But then we did an exploratory subgroup analysis according to the age of the patient, race, tumor subtype, and axillary surgery. And there was no significant difference in any of the factors except tumor subtype. And with the tumor subtype, there were some interesting findings, to say the least. Whether they were spurious or they mean something, we'll have to wait for more follow-up. But for triple-negative patients, radiotherapy appeared to do worse if you don't get radiotherapy. This favored no radiotherapy. In other words, twice as much recurrence if you didn't get radiotherapy as if you did. I don't know why. I don't have any possible explanation for this. On the opposite side, ER-positive HER2-negative patients appear to get some benefit with a hazard ratio of 0.41, so about a 60% reduction. So obviously those patients potentially can get more recurrences in the future. We'll have to follow them. These patients probably is unlikely that will change because most of the events in triple-negative breast cancers have already occurred, I think, in the trial. And HER2-positive subtype did not seem to make a big difference. They were about a 1. So we have to be a little bit more cautious for ER-positive HER2-negatives, but for triple-negatives, I think my advice to patients that we see now is just not to give regional radiotherapy. But more follow-up certainly is needed. So in conclusion, essentially, we showed that it's oncologically safe to avoid radiotherapy, at least at this point of follow-up, based on the results of this trial. And so we'll see what happens in the future. What are some relevant questions nowadays for axillary surgery? Well, the two opposing trends here. One is, can we even omit sentinel lymph node biopsy? What do we need it anyways if we're not going to affect our treatment? On the opposite side, do we need to escalate axillary surgery to make eligibility patients eligible for these novel therapies that we have developed? So when it comes to the escalation of sentinel lymph node biopsy, avoid sentinel node biopsy, it's probably in the postmenopausal ER-positive HER2-negative patients that is sort of the low-hanging fruit. Because for those patients, we don't need to know the nodal status to give them therapy. We use genomic profiling. So can we avoid sentinel lymph node biopsy for these patients? Is local control or systemic control compromised? Again, the rationale is no therapeutic advantage for axillary dissection. We now have preoperative axillary ultrasound and core needle biopsy for suspicious nodes that have at least 80% sensitivity. And also, if you have a negative axillary ultrasound, it excludes N2 and 3 disease with negative predictive value 93 to 96%. In other words, if the axillary ultrasound is negative, you have almost 93 to 96% that you're not going to have 4 or more positive nodes. And again, for postmenopausal ER-positive HER2-negative patients, knowing the nodal status doesn't affect adjuvant systemic therapy decisions. However, having said that, nodal status and genomic classifiers can potentially dictate use of adjuvant CDK inhibitors, duration of endocrine therapy, and use of post-mastectomy and regional nodal radiotherapy, unless we found a way, as I showed you before, that you potentially can de-escalate local regional therapy because of genomic classifiers. So this may go away for at least low-burden disease. So what evidence do we have so far for omission? One trial so far reported, the SOUND trial by Oresti Gentilini. T1 and 0 breast cancer under 2 centimeters undergone breast conservation and breast radiotherapy, negative axillary ultrasound, randomization between having a sentinel biopsy with axillary dissection if there were a lot of nodes, but there weren't a lot, and then no axillary surgery. They have already shown that doing sentinel biopsy does have some postoperative disability. It's not an innocuous thing. About 24% in the sentinel biopsy arm versus 10% in the observation arm. And then these are the results, 1,463 women, median age 60 years, median tumor size 1.1 centimeters. It was T1, but again, low T1, as you can see here. Almost 88% of hormone receptor positive, HER2 negative. And again, in the sentinel lymph node biopsy group, 13% of the patients had positive sentinel nodes when they had surgery. Median follow-up was 5.7 years. And again, the results speaks for themselves. These were presented in St. Gallen a couple of years ago and published in JAMA Oncology. And you can see no difference in 5-year distant disease-free survival, no difference in local recurrence, no difference in distant recurrence, and no difference in death rate. Of course, again, more follow-up is needed. Some of the overview analysis have shown that even 15 years later you may have events, so we definitely have to see more. There are other studies, and I hear that this INSEMA, which is a large trial from Germany, will be presented in San Antonio, I believe. So we're very interested to see the data from that trial. I don't know what part will be presented, but nevertheless, several other either randomized or prospective trials are examining the same question. The last topic, do we need to escalate surgery to allow patient eligibility for neoadjuvant therapies? That was debated a little bit earlier today. What therapies are we talking about? For example, chemotherapy in the responder trial for patients with 1 to 3 positive nodes, Oncotype DX of 0 to 25. For premenopausal patients, there was chemotherapy benefit. Postmenopausal patients, there was not. But what if they had 4 positive nodes and they only had a sentinel lymph node biopsy? Would they benefit? The monarchy with amebaciclib in patients with 4 or more positive nodes was the eligibility, or 1 to 3 with some other high-risk factors. Olympia, which evaluated olaparib in BRCA positive. Most of them were triple negative patients, but there were also hormone receptor positive, HER2 negative, and very few of them actually were in the adjuvant therapy group, so they had to have 4 or more positive nodes to get in. But if they were in the neoadjuvant group, as Thorsten already explained, it was a CPS-EG score of 3 or greater. So there was some notion that if you did an axillary dissection, you may make some patients candidate. And again, olaparib has improved survival. Monarchy, not so far yet, and the responder, not as well. But the question is, what is the likelihood that patients with 1 to 3 positive nodes, they have clinically negative axilla, they get a sentinel lymph node biopsy? What is the likelihood they have 4 or more positive nodes on axillary dissection? There's several data sets that looked at that, including the ACOSOC Memorial, NCBD in the Curie, Senomac, and all of those essentially showed about a 15% rate of 4 or more positive nodes if your sentinel lymph node is positive, right? So remember that number. And then, of course, there is a downside of doing axillary dissection. Lymphedema goes up. And here I'm showing you that this is what lymphedema is with sentinel lymph node biopsy alone, about 8%. With sentinel lymph node biopsy plus radiation, about 11%. And axillary dissection, 24.9%. And combination of axillary dissection and radiotherapy close to 30%. So the reason I'm showing you this is to say that between sentinel lymph node biopsy and radiation and axillary dissection radiation is about 20% more patients that will get lymphedema. So remember that. So pros and cons, whether you do it or not. Well, let's see. How many patients do you need to undergo axillary dissection to find one who benefits from chemotherapy in the responder trial? So we get a premenopausal patient. The IDFS benefits about 5% in responder. We know that about 15% of 1 to 3 positive nodes will be 4 or more, so 1 in 7. You multiply all those numbers. You need essentially, as Thorsten already showed from the Senomac paper, same analysis here, you need 133 axillary dissections to prevent 1 IDFS event in responder, 230 to prevent 1 distant recurrence, and 500 axillary dissections to prevent 1 death. The math really doesn't add. And again, this is how much more lymphedema you cause to these patients. Same analysis for the monarchy with amebaciclib. Again, the same rationale. IDFS benefit 7.6% so far, maybe get bigger in the future. And again, when you do the same math, almost 100 dissections to find one that benefits from abemaciclib at this point. No survival as of yet, and again, so many patients get lymphedema. Of course, this may actually go away as far as the CDK inhibitors, because the NATALEE trial that was presented again in the ESMO and got approval now for ribociclib actually had patients either with non-negative disease or all the N1 patients were included. So, and the NATALEE trial has shown very similar patterns of risk reduction here. At 4 years, about a 4.9% benefit. This is about what it was in monarchy. So you don't really need to know the nodes to make a decision anymore to give CDK inhibitors. At least for all N1 patients, you can do it. For N0 patients with high clinical risk, you can do it as well. And what they showed also is that whether you're N0 or N1 to 3, you still have the same benefit from the addition of ribociclib. So again, that problem may go away. So you can conclude from that, like in an editorial from Beth Minotor, although a minority of patients may be understaged by having axillary dissection, it doesn't mean they're undertreated. And although axillary dissection may be considered in individual patients, we should not routinely do an axillary dissection to make these patients eligible for additional systemic therapy. So, in summary, there has been substantial de-escalation of the extent of axillary surgery in the past 25 years. Sentinel lymph node biopsy is now the standard of care for clinical N0 with negative sentinel nodes and for clinical N0 with 1 to 3 positive nodes, 1 to 2, 1 to 3, you can argue. And then axillary radiotherapy has similar control of the disease as axillary lymph node dissection for clinical N0 positive sentinel lymph node biopsy patients. Neoadjuvant chemotherapy has allowed de-escalation of axillary surgery and will likely de-escalate also regional nodal irradiation if you convert to negative. And in postmenopausal patients with hormone receptor positive HER2 negative breast cancer, avoiding sentinel lymph node biopsy is currently being evaluated in several phase 3 trials, with the early results from the SOUND trial being very favorable. Routine axillary dissection is not indicated to safely apply the results of Responder, Monarch, and Olympia, and results of the NATALEE may eliminate the need actually for axillary dissection to use CDK4 inhibitors. And again, I'll close with this. I mean, this has been, it takes a village to get all these trials, and this is some of the protagonists in all of these trials over the years, and we're all indebted to them for all their trials. Thank you very much.
Thanks a lot. Terry, thank you very much for these two very, very interesting talks. I'm sure that you have some questions. Fine, perfect. No questions. We can proceed with the next round table. Thanks a lot. Oh, sorry. Prof.
Yes.
I have one question, Terry. NCCN guidelines recommend sentinel biopsy in patients with positive, clinical, not negative, but positive loads at ultrasound, which are proven on biopsy.
Right.
So they are already proven, biopsy proven, so they're already staged. Could you shortly comment on this?
Yeah, I think that those patients, as you were discussing before, those are patients that technically sometimes they get punished if they get neoadjuvant chemotherapy because you have positive nodes before, which you had before the chemotherapy, because it doesn't work very well. And then you committed to do an axillary dissection for those patients. For those patients, increasingly in the US, we started to do essentially a targeted dissection. You know, if the nodes are positive, and you do an axillary ultrasound, maybe there's a cortical thickening, you know, it's not like a 2 centimeter lymph node that's positive, and you biopsy this lymph node, then we do upfront surgery, we do targeted dissection, remove the clip node, and we do sentinel lymph node biopsy. And I think it's a reasonable approach to reduce risk of lymphedema, because these patients, even if you get neoadjuvant therapy, they probably have this node. If they sterilize, it's great, but if they don't, I don't think we need to punish them to do axillary dissection. We'll put them essentially through a Z11 with the idea that in Z11 axillary ultrasound was not applied. So some of these patients were there with subclinically positive nodes. They escaped the finger of the surgeon, so why should we punish them for more morbidity? And I think that's very reasonable. Yes.
Thanks a lot.
Well,
Thank you.
Thank you.